Thank you, Manos, and thank you, all of you, for being here today. I know it's a beautiful spring day in Minnesota, and you'd rather be outside doing things and whatnot. So I'm going to ask another question because he took my question. How many of you have more than one stent? All right. All right, I'm going to try to tell you in the next 10 minutes how we got to this point. So I'm going to give you a little bit of context so the next talks become more natural. So the first angioplasty procedure was done when I was 2 years old, in 1977. The physician you see there, Dr. Grunstick, performed the first balloon angioplasty, and you can see his assistant is actually making the balloon in the kitchen. This procedure was done in Europe, and it really changed the way we approach coronary disease. Before that, the only option was really some medications and occasionally bypass surgery that was also being developed at that time at the Cleveland Clinic. Balloon angioplasty was the first step, but was not the end of the story, because what happens when you stretch a vessel, the natural response is what we call in medicine elastic recoil. And the best example is what happens when you inflate a balloon. The balloon, the minute you stop inflating air inside the balloon, will quickly adopt its original form or shape. And that's what we saw in the cath lab. And Nick probably remember those days when we struggled in the cath lab because we didn't have stents. So what are stents? It's really a device that is designed to maintain the luminal integrity of the vessel. There is actually a dentist who was called Charles Stent, who developed a prosthesis, and he got the name of the device, but it's really a device that is used to extend or stretch, fixing in an expanded state. That's the definition of a stent. And you can see in the United States, the overwhelming majority of angioplasty procedures are done with stents. It is exceedingly rare that we just balloon an artery, don't put a stent in it. Usually it's because the vessel is too small, or for whatever other reason is not suitable for a stent. But that is the exception, is not the rule. So the first stent was on the left, was actually designed not so much for the heart, was designed for the legs. Dr. Palmaz, who invented the stent, was not a cardiologist, was an interventional radiologist. And he was thinking about how to treat patients that can't walk because they have blockages in the legs. And then he partnered with a cardiologist, Dr. Schatz, and they decided to take this to the next level. How do you make that device that is fairly rigid on the left side of the panel so that we can deliver it to a very small, tiny arteries in the heart? And what they did is they essentially created a connection between different parts of a stent so that the device is more flexible and can travel down those vessels. And then this was approved by the FDA in 1994. This is when the first stent became commercially available. And after that, he did what any reasonable person would do. Move to Napa Valley and start making wine. Because he did very well for himself. So you can go visit his winery, you can have dinner with him, he'll sign one of these bottles. He has a collection of cars, as you can see. He's doing very well. So how do we get a stent? How do we get a stent to the coronary artery? Well, there are two ways of doing this procedure in general. One is we can access your wrist, and that approach is called radial approach. Or we can access your groin. And your physician will decide which one is better for you depending on the complexity of the procedure. But there are some advantages of doing it from the wrist. In general, when you ask patients who had both procedures done, I think the overwhelming majority will tell you, I prefer the wrist every day of the week because I can eat in a couple of hours, I don't have to lay on my back for so many hours. And for us, it's important because the risk of bleeding tends to be less with that approach. How many of you had it done from the groin? And now, how many of you had it done from the wrist? So both, I say both. Which one do you prefer? Wrist. What about you? Wrist too. Do we have any voters for the groin? One. So 3-2. Okay, good. Good. All right, so this is a stent procedure. A real stent procedure involves first taking pictures. On the left side, you see there is a blockage there in the front vessel, also called the widowmaker or the LAD. And then we inflate a balloon inside the stent to deploy the device. And at the end, we like to see this result when essentially we push the cholesterol to the side, and now we have restored normal flow to that vessel. And this is the outcome that we see almost daily in the cath lab. It's very, very gratifying. Now, this was not a perfect procedure. Even when we had stents, there were problems with the stent. And for many years, we had to hear this restenosis, so forming a scar tissue within the stent. It was perceived to be the Achilles heel of this procedure. This is essentially how the process looked like. You have a lot of scar tissue inside the stent, and that essentially leads to symptoms again. So patients will come see us again after a year or 2 years. I have angina again. I have chest pain again. And at that time, we'll have a conversation about putting more stents or perhaps considering bypass surgery in many cases. Until we came up with this. I didn't come up with this, but it was a great idea. What if we start putting inside the stent small amounts of chemotherapy drugs? These drugs are known to slow down this process of scar tissue formation. They're shown here as these little purple dots. So what they do is essentially they prevent tissue from growing inside the struts of the stent. So this process is not out of control to the point where then it will block the lumen of the vessel again. We have multiple stents now in the market. I would say the overwhelming majority of stents that we use today are medicated stents or drug-eluting stents or DES. And this is not for you to know, but every single company has a different drug attached to the stent, or a different type of stent design, or a different type of polymer in the stent, and we test them all the time because there are new products coming out all the time to the market. And this is how we want the vessel to look after we put a stent. Now we can actually, with this level of definition, we can look inside a vessel with a specialized catheter called OCT, and we can see the struts of the stent, we can see how the vessel looks inside, whether there is a scar tissue formation, whether there are any issues with the stent at the edges. So there is no ambiguity about our outcomes. We can see exactly how the stent looks after the procedure. Medications, after you go home, you're going to be taking a lot of medications, and Dr. Miedema is going to talk about that so that we don't see you again. Not that we don't like you, but I assume that you prefer to stay with your family, not in a hospital. But there are two medications that I want to emphasize because these are really important to prevent clot formation inside the stent. So that, you know, the few cases that I think we all have seen over the years, when we have clot inside the stent, it's usually not a very good procedure for anybody, for the patient or for us, the operators. So we really emphasize that these medications are very, very important. We don't want the platelets going crazy inside a stent. So aspirin, we typically recommend a baby aspirin for the rest of your life after a stent procedure. And there are other drugs like Plavix. It was the first one that we used for this indication, but now there are other two like Prasugrel and Ticagrelor that we recommend to use for at least 1 year in the majority of patients. Now there are situations where we may say perhaps 6 months is okay, perhaps 3 months is okay, perhaps 2 years. It depends on really the complexity of the procedure. So your physician will make that decision. But in general, we say 1 year. And what these drugs do essentially is they block the platelets. The platelets are the cells that essentially come together to form a clot inside the stent, and that's what we don't want. And there are drugs that bind to this receptor in a reversible fashion, or they just block the receptor until that receptor dies. There are cost differences, and we want to know about this. Our nurse practitioners do a great job in making sure that you can afford your medications. As you can see, there are significant cost differences, at least in 2012. As these medications lose their patents, the cost will come down. But we really want you to take at least one of them. So if there are issues with affordability, we want to know. And these are the situations, these are the variables I think that we as physicians consider when deciding for how long we're going to ask you to take these medications. And this is essentially, it's called the DAPT score. We use this, I think, in routine clinical practice to decide, are we going to treat you for just 1 year, or you have so many layers of stents, and this procedure was so complex that we prefer to prolong that to 2 years. Dr. Bilakis and Dr. Berg will talk about chronic total occlusions. So this is a discussion that you want to have with your doctor. On the other hand, if you're a patient that is at risk of bleeding, we may want to decide, well, maybe 6 to 9 months is all you need. We only put 1 stent, and we want to balance the risk and benefits of that procedure. So, but in general, 12 months is what we recommend. In some situations, we may deviate from that norm. With that, I will stop, and I'll turn it over to Dr. Miedema.